Okay, let's go.
All right, greetings. First of all, I want to invite my good friend, Soetikno, who will be sharing his thoughts on dynamic injection. And he's the one who came up with this term to make us appreciate that it is a different type of injection compared to what we used to use for sclerotherapy. So let me ask Roy to take it from here. Roy, thank you.
Thank you, Raju. I'm very pleased today to discuss dynamic injection, and I'm joined with Raju, Selfie, Sovia, Ravi, and Sriram. Thank you so much. We would like to acknowledge Dr. John Sroline Distinguished Professorship to Raju, the grant from Mr. Charles Budd, Angel Gill, and the UT MD Anderson for allowing us to use this platform. What we will discuss today is the safe resection part of this framework on how we manage large colon polyps. So we will not go to the details of the appearance, classification, and enhanced endoscopy, but instead we will take a small part of safe resection and discuss just the part about injection. So dynamic injection. This is a diagram that tells us how dynamic injection takes part in the inject and cut EMR. Later on, we will talk about ESD, and the same technique applies there. But what it is that rather than having the injection being stationary, whereby the needle and the tip of the endoscope doesn't really move, we actually maneuver the either one, both, or even with a torsion in order to obtain an optimal submucosal injectant. So in this step, we showed that there is a little bit of detour of the injection. And I like to just remind that on step number 5, we actually have the slight lifting of the snare before we perform the resection. Therefore, we have multiple stops during the procedure, or multiple steps during the procedure, whereby we actually ensure the safety of the resection. So this is the difference between static and dynamic. Static was perhaps first thought about when we wanted to perform epinephrine injection for peptic ulcer disease or sclerosing for varices. Sometimes in the 1970s, Dr. Dale said, well, maybe this would help preventing perforation during polypectomy. We subsequently thought that it would be, it should be added with the movements of the tip or the endoscope in order to make it dynamic, and adapted it for our resection. So how does it look like? This is perhaps the simplest injection. We're going to tip up, 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 suction, suction. Sometimes we have a readout during this procedure. That's okay because we know exactly where the tip of the needle is. So we cc or so, and we have achieved a large submucosal injectant. I think the distance between the lesion to the musculus propria by this time is very thick, and the risk of perforation has become almost zero. So this is another example of the simplest dynamic injection. Here, rather than tipping up, we decide to pull back the needle. Therefore, as the injectant accumulates under the lesion, we actually develop a large bulge. Had we kept the needle stationary, we would have made almost like a pancake of submucosal injectant, and that wouldn't help anybody. If anything, it would actually make the resection much difficult. Here, another example. We say, okay, the lesion is actually end phase, and we will need to pull back in order to make a very localized and generous submucosal injection. So you can see that maybe after 2 cc or 3 cc, we already have a large submucosal injectant and accumulating, and then all we have to do is just snare it off. You can see that our snaring is quite far away from the musculus propria, and we rarely would actually see injuries to the musculus propria. How about a more complex steps? So here, the lesion is not exactly facing the lumen, which is like at 12 o'clock. So we need to adjust the lesion by pulling it to the left side and then pull upward. So here is very much simplified, but the process is actually more complex than that, because as we move left and up, we also will need to suction the lumen to make it softer and thus allowing the submucosal injectant to be accumulating. You see on the bottom right corner that the amount of injection, even though it was only 3 to 4 cc, was very substantial. And you can imagine that a resection like that would be much more safer because you are far away from the musculus propria, but you're also far away from the larger submucosal vessels, which typically course just above the musculus propria. So here we have separated the lesion from both structures, the muscle and the larger vessels, and thus we won't injure either one of them or any of them. I'm going to just stop for a second to hear if there's any questions of the technique.
So one
Any
thing
question?
that I want to comment, Roy, it shows up your engineering mind.
Okay.
I think for those of you who don't know about Roy, Roy did engineering as his bachelor's degree, and you can see how he actually tries to break down everything that happens in a continuous motion into different steps. It's beautifully done, Roy. It's hats off to you.
Okay, so let's break it down even more. So first step, you must have a plan. Okay, it's like you're about to fly on an airplane, and you're the pilot, and you would say, I need to have a flight plan. I need to know where this lesion is going to be going to after I'm done with the injection. So that's step number one. So our plan is leftward and upward. So left first, and then suction slightly, and then you ask your assistant inject fast, because the injectant needs to accumulate rapidly under the lesion, which is now really being pulled up. It's being stretched out and far away from the base of the muscularis propria. So inject fast, inject, and then sometimes you have a slight correction of the flight plan. That's okay. Then you just have to basically know where you're going, and then you just adjust appropriately. So that's what we mean with move dynamically. Sometimes you may even go into a cloud whereby you actually have a readout, but you know exactly where the tip of the needle is, and you shouldn't worry that much that you are into some other structures. So everything is planned, everything is dynamic, and there is a lot of coordination between you and your technicians. So the fulcrum technique is useful because all you have to do is just import the tip of the snare onto the opposite wall and then close it, and then do the maneuver to ensure still that the musculus propria is not entrapped, and then we cut it with typically with some normal surrounding. So here, let's just think it through how we would want to do this, because the lesion is facing away from the lumen. So your flight plan would be in order for you to go into the lumen, you need to go right and then downward. Can you do something like that? Sure, you can do something like that. You just inject, pull to the right, so tip your endoscope to the right, and then pull the lesion downward. And then at the same time, you ask the technician inject fast. So on figure number 3, just right before you pull downward, you ask the technician inject fast. So you can see that the flow of the liquid will be very rapid. It will be directed towards the muscularis propria, and it will fill just right there. Okay, I'm going to take a 1 second break. I'm going to let you ask questions.
So I want to make a comment here. One thing is, first of all, I want to thank Roy for sharing this technique with me almost several years back. And once you try to figure out how to use this technique with the so-called dynamic injection, that is means, you change the path of your flight depending upon the circumstance to get a nice big lift. All these injections, my guess is less than 3-4 ml. You don't need 10 ml if you really get into the right plane. And the second one is, if you know how to do dynamic injection, you can get a good lift for a safe resection with just saline. Not necessary to use any viscous liquids. And you can actually achieve a lot with a simple saline solution, and something to keep in mind, And the second one is, this type of lift is a much more softer cushion that makes your resection much more easy to do, Sometimes if you make a mistake and if it is like a pancake, not like a nice mound, with saline, you can still resect. With any of the viscous solutions, your snare tends to slip off because it is too stiff and it cannot catch it.
Okay, thank you, Raju. So this is in steps, more detailed. To the right, down, and then you let go. And then the snare is with normal margin. So again, this is a much harder lesion, very flat. So first, have a plan. Here we plan to go upward, and we're going to inject from the back side first, and then suction as we inject. So now we are on figure D. Inject rapidly, suction, going upward, And then we say, okay, now I've injected the back. I need to inject slightly more on the front side to make the lesion more equal. Now it's like tilted to the front. You would want it to be much more flat, horizontal. So then you inject the front side, and then you can resect it. You can see the resection margin can be quite clean. The snare that you would need to perform something like this would be a stiff snare, because you really have, as Raju said, you have a lot of submucosal injection, and it is soft, so you need something that's relatively stiff in order to capture the lesion very well. This is a difficult lesion because it has been cut before, but here you would say, okay, how do I, what is my plan? My plan would be up. Well, let's see what happened when we go up. Well, some of the lesion is on the back side. So maybe it is a little bit difficult for us to see where the snare is. So then your next plan would be, okay, I'm going to actually now move the tip of the needle downward so that the injection is going to tilt it so that the lesion is more facing me. So just like that. So by doing it downward, you peg the lesion towards the wall, and then you inject the back side. I think it may be difficult to explain all of these without a movie, but we will share a movie later on. So if we had just done continuous upward injection, then some part of the lesion will not be seen. But here, by pegging it downward, then we fill the back side of the lesion. So backside, what I mean is the proximal side of the lesion. You push the lesion downward. The lesion cannot lift up at that part. The part that can lift is the proximal side of the lesion. So that's how this thing works, and that's why at the end the lesion can be captured, and we can see all sides of it during the snaring. Here's in a movie form. So we are going to now inject quickly, suction, 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 upward, 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 even upward, more even upward, maybe about 7 cc by this time, 6 cc's, 7 cc's, and then trying to really pull it against away from the musculus propria. And then we see, okay, after the injection, we see something like that. It's a little bit tilted the wrong way. So now we are going to inject the proximal side. And again, similarly, so we are filling the wall far away. Inject, 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 suction, suction, suction. And then there is a plenty of cushion by this time. So the lesion is now should be somewhat facing forward because we have filled the proximal side. You can see, okay, now is a good cushion, and then we are just going to put the snare on the fulcrum side, and then we are going to open and really positioning the snare somewhat in parallel to the circular muscle of the colon wall. So the colon wall will stretch more on the circular side. So we push it that way, and we prevent any musculus propria to be entrapped. So what do we do at this point? What we always do is that we need to loosen up. So here we're going to open slightly, loosen, look up, close, and then snare it off. And then we're done. So we've been doing this type of injection for quite some time, at least from 2009 or so. And with this type of injection, never in our mind crossed the idea that you would need a resection using the underwater submerged technique or the cold snare, whatever have you discovered all of this time. But really, there's a simple way to inject and to do it safely. So here you have a big lesion near the cecum. And I want to share with you the idea that a resection, the injection, could be going downward, and why downward would work. Okay, so I'm going to look up shortly. Look up. And then I need to peg it down. I need to look down so that I can feel the proximal side. Because otherwise the lesion will just move upward. In order to feel the proximal side, I need to peg the distal side downward and then fill it up. This is the final figure. I will not go to the detail of this one at this point, as I just wanted to slowly bring it to your attention that the movements of the dynamic injection could be quite diverse and requires really almost like this is what I think as the art of endoscopy, whereby the operator really think like this is really not described in the textbook as a definite as the step-by-step, but just the general principle is described, but the individual and how you do the steps will require your imagination and creativity. So again, we have described this part. I strongly emphasize step number 5, whereby you loosen the snare and then lift up and then cut. So here I'm going to describe in very detail different steps. So here's a lesion, and most people would just inject towards the lumen. No, we would need to actually inject and peg it downward because we need to keep this part, the distal part of the lesion, to have less fluid, while the proximal side to be filled. So here I'm filling the proximal side by keeping the distal portion pegged downward. I don't know if you can appreciate it, but that step again is filling where the needle is right now. Okay, so I'm going to play this again. Okay, I'm injecting there, but the injectant will all accumulate on the proximal side. It's a little bit counterintuitive, but here I'm pegging it down. I'm telling the assistant, inject, 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 a lot, fast, suction, and then I'm peeling the proximal side. So here you can inject 5, 7 to 10 cc's, and then suddenly you will be filling the proximal side. I'm going to share more images. I'm still filling the proximal side. Because I want the lesion to be like facing me after I finish the injection. So the lesion is pretty much now facing away from the cecum, and you can see now the lesion is ideally positioned for a resection. So here is the resection. This is after about 25 to 30 cc's of injection. And the resection is very easy is because you know that you're not going to cut the musculus propria. One, and then you just do successively. The most important is that the first cut needs to capture the edge. The second cut will need to capture part of the first cut, and successive cutting is then done using a 2 centimeter snare. So a lesion like this probably would take about 15 to 20 minutes to cut, because from the beginning you know that your injection is very, very assuring that you have given a very generous margin to the musculus propria.
What was the solution?
Just saline with indigo carmine. Okay, so that's 4 or 5 cuts. And now I'm going to share with you how do you do the backside, because there's a large part of the lesion that hasn't been cut. So you see the strip that we have cut, that's about 1/3 of the lesion. There's another third that's facing us, but then there is the last third that's facing the cecum. Okay. So this part is easy to cut. Okay, and then here's the backside. So the backside will need to be filled, and then your pathway is going to be upward and then to the right, because you want it to be tilting towards you, not towards the cecum. So here, while the assistant is injecting, I peg the lesion to be facing towards me. So here I'm filling the cecal side of the lesion. So I'm sculpting this lesion to be facing me and make my life easy when I resect it. So there's this area here that needs to be injected. I'm going to inject and then upward, and then even like torque to the scope to the right, so that the lesion will roll towards me.
Beautifully done.
So now you have the lesion very well cushioned. Suction, 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 and suction. Inject fast. You really have made it with very generous cushion, and then all you have to do is just apply the stiff snare. We would want to capture as much of the normal as possible. And here you see you can open the snare and make it to work like a scissor, and you cut the backside. So there's a lot of understanding of where the plane is, because here you're working on top of a ridge, on top of a fold. So you shouldn't really cut and deploy the snare across the fold, but you want to open the snare parallel to the fold, whether you're on the front side, on the top side, or the back side. It has to be parallel to the fold, otherwise you will cut the fold, and that's where cutting into the musculus propria occurs. So always think of opening the snare almost in parallel, if possible parallel, but fulcrum parallel is not easy, but if not, somewhat slanted, and then you are aligned with the direction of the circular muscles. At the end of any of this resection, we always use APC. This patient has a big lesion. There's really no point of saving $10 so that, or $20 or even $50 just because you don't want to open an APC probe. It's well critical that the lesion has no recurrence when we come back. So here is clipping it, and we've talked about clip many times before, but we would want to close something like this. The purpose of the APCs before are really twofold. One is really we want to cauterize any possible remnant along the cut side, the overlapping cut, even though we think that's unlikely. But another part that's also important, I think, is that we wanted to ablate any visible vessels that could be causing delayed bleeding. So here you can see that the lesion is somewhat wide. There is like a layer of coagulation that has been performed. So then in our setting, the recurrence rate of something like this is very small. It's less than 5%, and it's usually a very small tubular adenoma at the edges. So you can see that it's everything is very regimented, very stepwise, and that's how we can then perform resection like this. So here we are going to just approximate the middle side. A lot of suction when we clip, and then more clip, and then maybe one or two more clips, and we are basically done. Questions?
I want to make one comment. I think when you want to resect a polyp using EMR technique, it is important to get into the habit of looking at your flight path, where you want to bring the lesion for resection after lifting it. And as part of that game plan, try to minimize the number of pokes or injections. You should probably try to get, if it is a 20-millimeter lesion, you should be able to actually lift the lesion with one injection, one puncture. That is something where, and then direct your needle in the way you want it to get the lesion where you want it. That's a concept you have to keep it in your mind. For those who do ESD, they are in the habit of making those peripheral cuts. So they try to make small injections. That's a little bit different when it comes to the mindset of somebody trying to do EMR. So something to keep in mind, you know.
I think the dynamic injection allows what Raju just said, because you're sculpting the submucosal cushion, and you know, the point of your injection is not necessarily be the center of your cushion, because you're sculpting it. You're directing the flow of the liquid to where you want the liquid to be. Okay. So here I just want to share with you. Go ahead, Raju.
No, you finish up. You finish up. I'll make a comment later.
Here I want to share with you of the torsion of the tip of the scope that we do. So here is a retroflex somewhere in the right colon, and just filling it, suction the lumen as we inject, suction, and I'm really trying to sculpt it. So here I'm pulling the lesion to be away. Here I'm going to say, okay, I need this lesion to flip towards me. So therefore, I'm going to peg it downward. So down and to the left and up. There's a readout, that's okay. I know exactly where the needle is. And there's the lesion. It's not enough. I need to even make it so that it roll towards me. So I'm going to inject, and then make it roll by torquing it. So I need to like move, see, that's like me torquing it. I'm torquing it leftward, and now the lesion is like facing me. Do I need to cut it in one piece? Maybe not really necessary. We will cut it in a couple of pieces. So I'm going to cut the part that's facing me. Cut. Am I worried that I'm going to cause perforation? No, because I have injected and caused like a 1 or 2 centimeter cushion that will be there to ensure that my cutting is safe. So unfortunately, there's a little piece, but that's not a big deal. Just finish it. Always just APC, whatever could be remaining at the bridge. APC the vessels. There's another vessel there. Just a very light touch of APC beam. And done.
So I want to make a comment. I think you have shown this beautifully for the sake of our colleagues. If you think about the colon wall, the submucosal compartment is probably the loosest compartment, or you could actually say it is a compartment that can act like a balloon if you inject fluid. Think about a balloon, right? When you squeeze a balloon and the fluid goes from one area to another area, right? You can make those shapes with your balloon. It's the same thing. That's the same concept that Roy demonstrated here by injecting at one place and then closing that small compartment portion, the small area in that compartment by pressing it down so that you squeeze the mucosa to the muscularis propria and open up another space that is where you want the fluid to go and redirect the fluid in that direction so that the polyp comes where you want that polyp to come to. So it's a fascinating thing how the submucosa behaves.
May I ask a question?
Sure.
Thank you, Roy, for sharing with us this beautiful example of expert performance approach in which you deconstructed all steps in performing high quality EMR. I was wondering, in case of a lesion which has been previously treated and where there is fibrosis and tethering, do these steps apply? Are they the same, or do you have additional comments on that?
The dynamic injection cannot cancel or negate a non-lifting sign lesion. It cannot really undo fibrosis, but you still can inject a whole lot in order to cut it. It will also be limited in the IBD setting, although we still do it because we want to inject as much, even though the space will only permit as little as it is. So the answer to your question is that no, it cannot really break it down. Maybe it will have more of an effect as compared to the static, because you're actually pulling the submucosal fibers apart. You're actively like putting your finger there and then like pinch it and pull it away.
So let me make a comment here. I think Sylvia brought up a very important point, especially for people who do EMRs that are referred to them after having had multiple biopsies done. Right, Sylvia? That's the question.
Yes.
Or maybe a little bit of resection. So most of the time, if you think about it, if I see a polyp and I don't resect, but I'm in the habit of taking a biopsy and referring to somebody, I end up doing the biopsy on the anal side of a lesion, right? You don't necessarily go to the cecal side. That's the easiest to biopsy. That's where we biopsy and move out. Initially, when I was doing my EMR, I used to inject on the anal side without looking at where the scar was. And I ended up creating mucosal blebs. So then basically I failed doing the EMRs in those cases and required a referral to surgery. So nowadays what I do is when somebody sends a patient, had been biopsied, before I inject, I scan the entire area first, figure out where the scar is, and go exactly to the opposite side. And then start injecting on the opposite side. And when I see scar, I try to say to myself, I want to get as much lift as possible with one single injection. And that way what happens is you get a good lift, and maybe there is a little bit of tethering where your scar is, but you can still do a good resection. So learning to define where the scar is and staying away from that, and also going to the opposite side of the scar. That means if the scar is at 6 o'clock, I would go to the 12 o'clock and then start the injection.
Okay.
Hi, Roy. Can I ask a couple of questions? When you decide to inject, do you always start from the cecal side of the polyp or from the anal side of the polyp, or it doesn't really matter with dynamic injection because it anyways infiltrates through all planes?
No,
And
yeah, go ahead.
And the second question is, when do you actually inject through the polyp or go through the lesion? Do you always try to avoid going through the lesion, or in what situations do you inject inside the lesion? And the third one is, do you notice the dynamic injection? There is a difference when you want to lift something in the rectum compared to those that you want to lift in the right colon.
Okay, so the first one, we actually can inject anywhere. I think this one example, we inject more towards its right side. Do I always inject outside the lesion? No, but that requires a lot of optical diagnosis because a lesion like this, for example, we would never inject through its middle. Because this is likely to be an invasive cancer. So anything that's a high grade or cancer, we wouldn't inject through it. But something that's simple adenoma or SSA, I think that's okay to inject. So I think with a few more examples, you will see that injection doesn't have to be in the middle of the front side. It doesn't have to be in the center. It doesn't have to be on the cecal side first. It depends on the width of the lesion. So if the lesion is like very wide, you may want to inject on the cecal side so that it doesn't flop away from you. But if the lesion is not very wide, you can inject from the front side and then just sculpt it so that you can make a submucosal injection that's very generous, and the lesion will flop towards you. Okay, where is Suber? Suber, what do you think this lesion is?
This lesion, I will go with the according to the NICE classification, it's NICE 2.
Okay.
NICE class 2, and then it's like Paris class 1 SP.
Okay. Who's making those noise? So I'm going to share with you. So when you talk about the lesion, and I hope we talk about the lesion again sometimes soon, but you look at it first from far away. and then you say, okay, this is a flat lesion. The question is that is there a depression in the middle of it? Depression is, however, difficult to look at without indigo carmine. And then we say, okay, I'm going to spray indigo carmine, but it will be done later. Now, what is the NICE classification? The NICE classification requires you an NBI. You cannot really do a NICE classification properly without an NBI. So here is the what you're talking about. So here, when you look at the lesion, the center of the lesion, there is part that seems to be, oh my God, who has gone in there and then chewed the top of the lesion because it's missing, and it has all of these vessels that just at its end. It doesn't go around. So if you look at the picture on the right, and then you look at the direction 7 o'clock to 9 o'clock, those are adenoma. The blood vessels go around the crypts, while on the other side, there is really nothing going around. So we call this amorphous. We call it missing. So here's the amorphous part being shown. The blood vessels are not going around. It's just like its end. There is really no pattern to this. Compare it to the one at 9 o'clock. Those are adenomas. It
Right.
goes around, it hexagonal.
Right.
Yeah.
Show the vessels with your marker, with your pointer, so that people can appreciate what you're talking about. When you say the crypt is surrounded by a blood vessel, that is a normal or an adenomatous crypt, and what is the type of vessel that makes you think it is probably cancer? So start with the adenoma. You may want to back up your video a little bit.
Okay, there's adenoma. You see it? This is cancer.
Yeah.
Yeah.
No, but
Okay.
point with your thing where the crypt opening is, and all.
Can you see my cursor?
Yes,
No,
it's
right?
moving.
Yes.
Okay. Come down.
Oh, okay.
Yeah.
Okay. So this is a hexagonal or pentagonal of blood vessels. The crypt is in the middle of it. Okay. So this is just like one complete gland. It hasn't been destroyed. There's another one here. This is, with the shape of it not being hexagonal. So that's a characteristic of an adenoma. But here,
Don't go there. Don't go there. Go from there to the transition area where the structure is getting destroyed to the cancer. So take it.
Okay, here is the transitional part. Okay, all of these. Thank you, J-Dash. And then all of these is probably has been eaten by the cancer, meaning it's been destroyed. And you have the cancer destroying it. There are very few things that would destroy the mucosa. And here is just ends of the blood vessels. There is no pattern to it anymore.
Thank you.
Okay. So as I said, it's hard to appreciate depression without putting blue fluids. So here the blue goes into the border between the depressed area and then the normal height area. So here, you can see that there is an area that's depressed. So this is a depressed lesion actually. And you know that a depressed lesion of this size, maybe about maybe 8 millimeter, 9 millimeter, is the submucosal invasion risk is somewhere about 10% already. So I'm done. This patient, unfortunately, is not a surgical candidate, but I still would want to get a very good cut. So here I'm going to show you how we use the dynamic. We are injecting from the right side of it. And I say, okay, I injected partly. And you see that that one injection from there actually filled this left wall. Now I'm going to inject more. I'm going to tilt it so that it becomes level to my eyes. I wanted to do an ESD here. So I'm just going to inject around. Like what Raju said, I wanted to have a very good cushion for the circumferential injection. So now I have this circumferential cushion that's very, very thick. I'm not going to perforate anybody by doing this. So I can rapidly actually perform a circumferential cut. So I'm going to cut generously. It's a small lesion, so it didn't take that long. But I'm going to make a fried egg looking lesion after I'm done. It's important that we cut beyond the musculus mucosa and cut into the submucosal layer. So now I have an idea that my flight path needs to go down and to the left. I need to connect to my prior cut on the other side. And then I'm done. Now the lesion has been isolated. There is a musculus mucosa that hasn't been cut. So I need to cut that. Make sure that I see blue because then I know that I'm in the submucosal space. Done.
Nice.
Okay.
Wow.
Then we just have to inject some more. I don't want to risk capturing the musculus propria because if there is some mucosal invasion, there is a possibility that that part is more tethered. So I'm going to just inject there more. Lift up, suction, lift up, lift up, lift up. I know you guys are from Houston and you think that the space shuttle is going up or whatever, but it's like that. It's lifting up. So lifting up, and then we are going to impact the tip of the snare on one side, fulcrum. We are going to loosen even. See, I'm loosening it. Loosening while tilting up, and then cut. And then it is a done cut. Okay. I don't have that much more time. Oh my goodness. So I'm going to go to the last part of my talk. This is a gift to Sriram, who wanted to ask, how do you deal with lesions at the anal first? How do you use dynamic injection? How do you deal with the hemorrhoidal plexus? So you see the lesion, it's been cut by somebody else, and it's a mess because then there's a lot of fibrosis, but still it's all looking benign. So I'm going to inject, and I'm going to inject a whole lot dynamically, suction, 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 and then make the initial cut. I want to show you all of the cuts on the proximal side, but I wanted to share with you how to deal with the cut at the hemorrhoidal plexus. So here is at the hemorrhoidal plexus, I'm injecting, or actually I'm cutting first. Hold on, there's a part that's I'm going to inject. I guess I don't show that. This is to share with you that the importance of a fulcrum technique. Sriram, we will get to the gift to you. 1 second. So with the fulcrum, you can inject flat areas, you can inject normal mucosa. And here's what we wanted to share with you. You're going to see a lot of the hemorrhoidal plexus. So those are the hemorrhoidal vessels, and you see that they evaporate, very rapidly evaporate when you apply APC.
What was your setting?
30 watts force. All of these vessels. Now, if you hadn't done dynamic injection and you hadn't done the lift up and tighten the snare, very likely you would have cut into the plexus or into the plexi because these plexi, as you can see, they run at the deeper part of the submucosal layer. So you really want to like lift up and then loosen and then close, and then you are not touching any of these plexi. And then all you have to do is really to ablate them. So here, dynamic, up, 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 up. Okay, I'm going to close it and then I'm going to open it. Close. This is probably using a 1 centimeter snare rather than the 2 centimeter because you need more control. So the movements of the upward was just in microseconds shown, somewhere around here. And then you end up with the blood vessels that's exposed. Those are something you don't want to be bleeding because you'll be busy. So those are just the hemorrhoidal vessels. You can see that this is the squamous anal site. All of the vessels are there. And then you do APC. Here's the APC. Now you know why I don't use the tip of the snare, because you want an even cautery. See how they just evaporate, there's nothing remaining afterwards? Yeah?
Yeah.
Yeah. Okay, I just want to conclude that your purpose is really to prevent perforation and prevent bleeding. Don't forget though, even though you do dynamic and you're generous, you will still need to do lift and loosen. And fulcrum is helpful because you have a very soft basis. I would want to say that in the big scheme of things, you would want to just learn a couple of techniques that work. You don't want to say, today I'm going to be doing underwater, tomorrow I'm going to be doing cold snare, another day you do something else. That will not work because the number of patients with these lesions are relatively small and you need to master something. You don't need to go to the DDW and be distracted by people who would want to just show off what they could do, but you would want to develop something that you actually can use to help your patient. So the dynamic injection allows you to have the full spectrum of any resection. That is not offered by the other techniques. And you would want something that especially Raju has talked about this many times, that your technicians can work with you. You don't want to be developing something that the technician should say, well, today, what kind of menu do you want, sir? Is this the fried egg? Is this scrambled egg or whatever egg? Then it won't work. The patients will be the one suffering, because then the injection, the cutting is not cleanly done. So that's all I have to say. Thank you so much.
Beautifully done, Roy. We don't have time, but I wanted to ask people if they have questions, because this is beautifully done. And I didn't want to conclude this session at 10:30. I want to give time for people to ask questions. I will have for 5 to 10 minutes questions.
That's amazing, Roy, what you did. So beautiful.
Thank you. Questions? Where is Ravi?
Hi, yeah. No questions.
Well,
Roy,
we
I
are
have a question.
spellbound, Roy.
Where
I have a
is
question.
Sriram?
We are
Let's hear from Sriram.
yeah, we are spellbound by your performance. It's really good.
I think we need to so the anorectal area is certainly a concern, and I appreciate your questions, because then I made me to look for these movies. But the strategy is really to make sure that there is no pain, right? So there is no pain at the time of the resection, and there is no pain subsequently. So at that time, you would want to say, okay, I'm going to inject a little bit of lidocaine. I'm going to inject maybe a little bit of epinephrine, and then I'm going to do all of that using the dynamic injection. And then when you are done with the cautery and all of these, then you would say, okay, sir, here's some lidocaine cream, and I'm going to put some so that it's not painful. But then when I'm going to give you like a tube of it, so that when you're at home and it's a little bit painful, please do take this. Usually when we do the EMR in this area, they actually don't complain that much. It is when we do an ESD there, then they have a lot more pain. So I usually just say, okay, here's the lidocaine, please use it as you need. And then they're usually very thankful, because you also need to explain to them, look, if this thing cannot be cut by us, this could be trouble to you. So because the surgical resection is horrendous. And I wouldn't think for a microsecond that the surgeon can do a better job, because they use their naked eyes to be looking at the lesion. And the naked eyes is not equipped to be looking at a flat lesion. You are in there, you have a 40x endoscope, and you see it very well. And even in this example I had shared with you, we use the NBI because our naked eye white light will not be able to tell us where the margin is. So now imagine the surgeon having to put their head down there, and it's like a mess. So we can do this, and we need to be confident that we can do a better job.
Do you use lidocaine routinely in the injection itself, or you just provide them the tube later?
No, in the beginning we do inject them a little bit of lidocaine, like maybe a couple of cc's there. I'm not a big proponent to inject lidocaine, because lidocaine have a cardiac effect, right?
Yeah.
So
yeah.
you want to be so you want to inject some saline, and then you inject into the bleb of it rather than injecting lidocaine directly.
And promises to get a few more anorectal videos time to time.
Okay. Try a small lesion, and then you see that if you do it right in a regimented fashion, then you can solve these patients' problems.
Aman, you have a question?
Yes. Hi, Dr. Roy. Very nice presentation. lot of learning lessons, from this. So one question regarding the EST cum EMR technique, the fried egg on the lesion that appeared to be cancer. Why do that hybrid thing? Why not do just the EMR or just do the full EST?
I don't know. I'm a big proponent of like doing it very efficiently. I know it doesn't take that much longer, but I say, hey, when you can just snare it off, why not just snare it off? Besides, there is more risk of bleeding when you do submucosal dissection. A lot of the risk of ESD is really the submucosal dissection. So when you don't need any of that thing, why bother? Just be done with it. Maybe it's too pragmatic, but that's the real reason to it. There's nothing else to it.
And if you would have done just the EMR, like you injected and you just
EMR?
Yeah,
it's possible, but here I wanted it deeper. I wanted. I know that EMR cuts in the middle part of the submucosa, but I wanted I want to get access and cut it in one piece. I didn't have time to share with you the pathology, but the pathology is very interesting. So despite all of that, right, you see my cut margin at the bottom, right? And the lesion is the cancer even is like within microns of it, okay? But the importance of this is that by having all of this nicely cut like this, we actually could show that there are like lymphatic involvements. Maybe somewhere here is the lymphatic involvement. So this is exactly the reason of it. It's like we wanted it like fully controlled. I agree with you. You wanted like the best control, just spend more time. But we thought that the snare, when you press it down, you get almost the same effect.
But probably your injection would not have been so efficient if you had not injected into the lesion after your circular incision, because you are going into the submucosal plane under vision. Whereas if you are injecting for EMR, you're injecting from the mucosal surface, and it's less definitive. It is more definitive.
I agree. I agree.
I think one take-home message is, I think one needs to keep this thing in mind. When Roy injected on the right side of the lesion, the lift went up under the lesion and also extended to the left side. And that indicates that your deep submucosa and even probably the middle third of the submucosa must be free from cancer involvement. Usually you don't see that when the cancer goes into the middle and the lower third of the submucosa. So it was a beautiful lift. The key is when you see a lesion like this and you don't want to do what Roy did, and you say, I want to do an EMR, what I do is I ask my assistant, okay, this is a lesion that you could cut with a 10 millimeter snare. It's not big. You make sure that the patient is grounded or set up for electrosurgery, and your snare is out on the bed, and you inject. And the moment you take your needle out, you get your snare and then cut it immediately. So you could actually, when you are cutting, and when I cut a particular lesion like this, when I want to cut, I want to make sure that I have margin, enough margin. And then as my snare is touching the mucosa, I try to apply a little bit of a coag to let the snare stick to the wall and then close. So that way, at least my snare is not slipping to the edge of the lesion. And you could actually, you could cut with EMR like Roy suggested. I think he probably took that extra step. The problem here is not necessarily the margin. The problem is lymphovascular invasion, right? If you have lymphovascular invasion, it doesn't really matter whether you have a clear margin or no clear margin. If the patient is suitable for surgery, they need to go for surgery. this patient is not suitable for surgery. So then you manage what happens in terms of following up the patient with CTs or whatever. All
Raju?
right. Thank you so much. Selvi, you want to make a comment? Yeah.
No, I just wanted to say in terms of transition on the histology, you can see at the 9 o'clock position that you can see the kind of normalish looking crypts, maybe adenoma, and how it kind of transitions to those abnormal crypts and the carcinoma.
Right.
At the top at like 10 o'clock of
Yeah,
the
you can
slide.
see the transition.
Yeah. And also at 3 o'clock, 3:30.
Right.
Anyway, it was a beautiful presentation, Roy. Mesmerizing watching
Thank
you
you
do
so
EMR.
much. Thank you.
Thank
Thank you.
you.
We're all
Bye.
grateful for you. Thank you, sir. Bye-bye.
Bye-bye.